You're listening to the Physio Matters podcast this month in association with rehabmypatient.com, and this is session 95. Welcome back to the Physio Matters podcast. I'm Felicity Thou, standing in for Jack Chew this month. I'm delighted to present to you session 95, not least because I have a fellow Geordie to introduce. This month, Jack Chew is talking to Steve Miller from Grow Physio about integrating sport and MSK. Sport can certainly part of the MSK family, but it can sometimes feel like there's a set of different rules and regulations for managing our athletic patients. And so it's a great conversation, all encompassing about the sporting world and how we fit good practice into that. With thanks, as ever, to Rehab My Patient, who are sponsoring this episode. Couple of webinars to mention that are upcoming. We have our podcast partner, Jo Turner, who hosts You Matter podcast. She's hosting a webinar. It's a workshop style webinar on Thursday, the 2nd of December, 7 till 9:30 p.m. And the title of that is What Next? A Complete Career Change or Just a Tweak? Joe's getting a lot of questions about career transitioning at the minute, and so this should be a really popular event. But whether a complete career change is needed or whether just a few changes can help. We've also got, you'll recognise these names from a previous episode, Dr. Karen Forshaw and Chrissy Mowbray from Resilience in Practice. They are hosting a choice of 2 dates for their workshop, all-day workshop webinar. That is Friday the 3rd of December or Saturday the 15th of January. And you can find tickets to both of those on our social media and on Eventbrite. If you search for Jo Turner Career Transition or Resilience in Practice Physio Matters, you will find them on social media. And so now all that's left is to hand over to Jack and Steve.
Delighted to be here today with Steve Miller from Grow Physio, who's had a really interesting career journey that I feel is going to be able to give insight to all of us for the compatibility and not between sports and MSK, even public and private sector stuff, often talked about on my Chewing It Over show, covered in several episodes in little bits across Physio Matters over the years. But I feel like it's well worthy of a dedicated podcast to kind of get into, where there's some ups and downs, some good and bad that can be when it comes to integrating sport and MSK. And I can think of no one better than you to sort of talk to about that. Makes sense for us to start off by you just introducing yourself for the listeners that might not know about you.
Yeah, sure. And I think for me, just a big thank you to you, Jack, for inviting me on, really. My background's a little bit mixed, as Jack sort of said, and a bit of an overview, really. So I started off in an NHS world. I did masters and went into sort of team leader roles there. Worked in semi-professional sport alongside that. And then my big drive really was to get better at rehab and really immerse myself into that world. And that really, for me, where I wanted to go with that was full-time sport, really. So I went and worked at Newcastle Falcons, which is a rugby union club up in the northeast of England. And that was a full-time gig, really, with the first team there. So I spent 6 seasons there. And then because of family reasons, we relocated 10 minutes down the road. And then hence sort of jumping into the Physio Matters studio, really, here. I'm now working down here in private practice and for Bupa as well as setting up, during the pandemic, a online educational platform really for physios, sports therapists, anyone who really wanted to develop their MSK knowledge and potentially sort of give some access into almost a professional sporting world, really. It's something that I feel very passionate about, and that's why I've set it up. I feel like it's been a world that people haven't had access to for a long time. And then therefore, the best sort of scenario that I could kind of come up with to give people access was do it virtually, really. So I hope it's been a useful resource for everyone involved. And excited to kind of talk about the differences, really.
Absolutely. Well, I think towards the end of it, I want to talk a bit more about Grow Physio, because I think it's almost it's become a natural endpoint for you to share some of that experience, but also fill some of the gaps that you feel you've observed where there's people that maybe would benefit from that knowledge, but it's often laced with a load of misnomers and misconceptions. And so to sort of distill that as you have done through Grow Physio, I think it's a massive asset to the industry and something that we're massive supporters of. So I think we'll naturally conclude there. But the journey that I really want to go on with you is that there's certain areas within sport and within MSK and across sectors really that definitely can benefit each other and enhance, and it sometimes feels like they're synonymous. But there are other areas where there's distinction that matters, and that sometimes that can break down conversation between, say, elite sports physiotherapists and other therapists in MSK in those environments, and those that are in a job in outpatients to either department, either in the public sector, or more classically in private practice with regards to, say, cash paid or insurance patients there. There are distinctions in sort of time, and therefore styles of practice, and therefore part of what is influencing your reasoning when making clinical decisions, be that even with regards to referral, access to imaging, all sorts of bits like that. Before we get stuck into some of those detail, as an overview, when you look at your career, which has been, what we consider now a fairly typical portfolio career, now even as an educator, how much do you feel that things have fed into each other and it's just part of that complexity, part of the mix? Or how much do you see them as distinct events where you do need to have quite a distinct identity at times?
Yeah, it's an interesting one. They're clearly different. They all come with different challenges as well, the areas that we work in. I think I've been quite privileged that I've actually managed to step into like a professional sporting world, something that I'd always dreamed of. But I think it's revolutionized my practice in terms of what I've drawn from that world and applied into maybe private practice as well. I think you're absolutely right. You nailed it completely with the time allocation that you have with people in a professional sporting world. It's very different working, I found, in a semi-professional world, working a Tuesday, Thursday evening and then kind of having a game on a Saturday, to being immersed fully in it. You do have more time. You can trial and error, I feel, a lot more. So you can look at a certain technique or a taping strategy, for example, and you can immediately go and apply that on a field. See, if we discussed a little bit earlier on about sort of the scenario where does taping fit in that world, really? And I think probably just to elaborate on that, if you imagine you have someone who's maybe got a biomechanical issue, you address that with some taping, be it you're restricting calcaneus, putting that in a more neutral position, for example. You've maybe got K-tape to enhance this tib post, whatever it may be that you're trying to achieve. Rehab is fundamental to that whole process. But what you can do is almost try and mimic that role, apply some taping, get them onto the field, into a gym environment, see how they perform with that on, and then almost adjust what you're doing. You can take that off again. And again, it just gives you that flexibility. Similarly with maybe a manual therapy technique that you do, I have become a lot more driven in and guided by objective markers and actually making measurable change within a session that you're doing. And again, you can see how that translates into the world that they're going to move into. I think that's been a challenge for me in terms of going from being able to do that maybe once or twice a day with people and having maybe half an hour in the morning, half an hour in the afternoon, and being able to observe their rehab and make sure all their technique's great, to then that sort of once a week or once every couple of weeks that you're seeing people in that. You go from an environment really where I think manual therapy has a huge benefit and role within physiotherapy, but when you can't apply it at the frequency or the duration or in the positions that you're going to on a regular basis, it does dilute it enormously for me. So then how I've changed my practice, I've had to adapt from that, because I appreciate that physiotherapy is such a valuable resource that you can draw upon and you can do all sorts of things that make a difference in the session. But actually, in terms of the carryover from that, what I've tried to move a lot towards is giving the patient that empowerment. So we moved very much from I suppose like a passive role in sport to getting all the players to do what we call professionalism. So come in, go through a checklist of tests each morning. So it would be a knee to wall test, a sit and reach test, a toe touch, an adductor squeeze, really, just to find out where they are at that moment in time. So it's live reporting. And I think what I've started to do a lot more in private practice is educate these people. There's no reason they can't, if they have an ankle or a calf or an Achilles problem, for example, do it their own knee to wall test, see where they are. Is there a corrective protocol that we can give them? So actually, if they are down on a knee to wall distance-wise and things are a bit tight or they're a bit stiff, they have the tools to change that rather than being reliant on physiotherapy. So you've almost got an objective marker, an intervention, and then they reassess that knee to wall in this sort of example, really. So then they are prepared for their run, be it they might be doing a couch to 5K or whatever it is. And it almost flags for me before that injury happens. So it is preventative. It is trying to reduce the injury rates that they're getting, or potentially if they are wanting to run, again, they always ask sort of, when am I ready to run? Well, you need to hit this marker, be it the number of calf raises that you're doing, the number of kind of hamstring. I had an ACL guy this week in private practice who had his ACL recon at the start of lockdown, hadn't had any physiotherapy. And again, you sort of go and he was asking me the question, when are you going to run? And you sort of go, well, in the worlds that we worked in before, we would do preparatory work to impact, and we'd kind of make sure that people were hitting a strength level that we were happy with. We had it as a rough guide of 25 single leg hamstring bridges that we would do. That's when you're ready. We did it on the bed with him. He got 9 on one side, 12 on the other. So he was generally a lot lower than we would want him to be to then get back into running. And I think the adjustment for me is very much that elite sport to then recreational level. But a lot of these principles apply, really.
You just got to modify them, and time seems to be the variable you're describing as being the massive one. I want to just zoom in a little bit on those examples with regards to when you've got that time and when you're able to do that test-retest type model on a regular basis, on a daily basis, rather than a fortnightly basis. The principles of the fact that many of the interventions we've come to understand as being sort of transient changes, be that say strapping the rear foot, say you mentioned say K-tape over the tib post, for example, that was just trying to offer some sort of proprioceptive feedback. If you then were doing any manual therapy techniques that we know then might make things more comfortable for them to actually participate in something that was crucial for that day, those changes being transient didn't matter in that environment, but then they just do on a fortnightly basis. One of the things I wanted to sort of invite were your thoughts on how, when we know those things to be adjuncts to rehab, and you've said yourself that you wanted to pursue an understanding of sort of scaling people's functional ability, and in this case for performance, but also for injury management. If that's where the centre of the bullseye is, and that's where we've spoken before, it's got rehab-centric practice. It sounds like we practice fairly similarly. We know that that's the centre of it. In private practice, or even in the NHS, when you throw back to when you were involved in that, if you were to try to do some of those things, they wouldn't be an adjunct. They'd need to be the centre of your care, because you literally wouldn't have the time for other things. If you were doing a test-retest on some of those interventions, it wouldn't be an accessory. It'd be the centre of it. And I think that that's where it becomes almost, in my opinion, controversial, is that when people think that there isn't really room for it. I know how time pressured I am with the education, with people understanding, for giving them protocols that they can comprehend their own performance to manage, because they're not with a therapist every day. That, for me, I know that I face those challenges, even though I only ever consulted within sport. So for you to have been in that world, has it been how easily has it been to adjust, and how much of what I've just described there does need to implicate your reasoning when in different environments?
Yeah, I think it all goes down to the clinical reasoning, and it varies depending on the individual who's in front of you in some scenarios. But I totally agree. I think that luxury, if you like, of being able to maybe apply a manual therapy, a taping technique, I know we focus a bit on taping, that's not the be-all and end-all by any stretch, but I think in terms of empowering that individual and getting the most carryover is where I've had to adjust the most. So I think probably, I know that you can make huge benefits with manual therapy, but I appreciate that, again, they are going to be hugely diluted if you don't do that frequently enough, or you don't kind of have a measurable change. And you definitely don't want to become the individual in front of you. You don't want them to be reliant on you applying that technique on a regular basis. You want to give them the tools so they can manage that. You don't want this person coming back to see you forever and a day. You want to almost get them strong enough really to cope with the load that they're going to expose themselves to, whatever that may be. So a massive shift from me, really, I think, in terms of, I probably started off naively when I went into private practice thinking, you know what, I'm still very aware that manual therapy can make great differences. And I think the huge difference often for me was we were trying to turn people around on a weekly basis. Sport is typically, say, Saturday to Saturday. So you get the kind of collateral damage that comes out on a Sunday when you do an injury clinic, and then you've got basically 5 days, probably even 3 or 4 days, to prove to the coaches that that individual is ready and going to be able to perform at that level. So therefore you have this, I'm going to throw the kitchen sink at this in terms of all the techniques and things that I can to give them the best opportunity to come back. With that comes with a real risk, because most people finish pre-season and they're strong and they're fit, and progressively as their bodies are more sore in rugby, they're less able to do all the extra work on strengthening things that we do, and they probably become a bit more reliant on some of that soft tissue to get them through. And I think the way that I've tried to kind of almost get my head around it is to describe it as in like fire. Manual therapy is like fire. It almost gives you that short-term heat response if you need it. I know you're going camping on the weekend. If you want to create some heat from somewhere and get through a night of living in the wilderness or whatever, you'd probably create a fire. You haven't got enough time to build a foundation, to build a structured, strong individual in the time it takes to get to a game. Whereas often in our world, people have and I say our world as in private practice, really.
Sure.
The world is they often have an event that is maybe, hopefully, a few months away, whatever it is. So therefore, you've got enough time to build this house that you're going to almost live in, this strong, structured foundation, platform, protection, so they can cope with the loading that's demanded. But often if they have a flare-up a week beforehand, there's probably little point in doing much more than some activation work, some neuromuscular fire-up. And then almost that's when some of that panic kicks in and you go, well, I know I can turn this round with what I've got, because you've got a good platform there, but I need that extra kind of fire for them to coexist.
So that's another great point, where the baseline that you're describing of the athletes, the specimens that you're working with, really matters, doesn't it? Whereby there might be those pursuits of what are often cheesily called marginal gains, but you've got that opportunity to know that someone is in great shape. And so the relevant and relative difference between those elite athletes and Joe Blogg's recreational runner, weekend warrior types, as well as then those more sedentary, means that it's just not the biggest fish to fry. And so the difference in the application of your skill set is going to vary dependent on that baseline. It'd be bizarre if you didn't account for that. One thing I do want to pick on a little bit is that we talk a lot on mechanism of effect on physio matters and stuff, and where that should influence your reasoning. I'm often describing in shorthand with patients, and generally speaking even into professional education, whereby manual therapies and other taping interventions, really, barring some good evidence we have at zinc oxide at the ankle with regards to ankle sprains, reckon first half of a game of football or rugby, you can make real obvious mechanical difference that then can last almost as a bracing type element. But more generally, those interventions seen as being a clever form of paracetamol, right? These are pain relieving interventions. But is it that you feel under that logic in a sporting environment, particularly when you've got people that are otherwise they've got the big things done well, you know, the high ticket items of rehab with strength, flexibility, general load management and competence and stuff, right? They've got all that together, high performers. Is it that you feel that really it's indicated to use some of those pain relieving techniques for them to be able to participate and prove their worth to coaches? Or is it that you feel that there is something that I'm missing by describing it as pain relief, and that there's actually something that actually it's an accessory to rehab in a way that I'm almost demeaning somehow by defining it as such?
No, exactly. And I probably put those into the category of what I put under the umbrella of the 1%ers, really. So you've got the foundation that's there, and all the extra bits that you probably add on to that in terms of manual therapy bits and maybe some electrotherapy stuff, if that's still kicking around, taping bits. I find that they're often like the 1%ers, but sometimes the 1%ers is what almost takes them over that threshold from being able to perform and not being able to perform. So I guess, I don't know, we'd have quite a few grumbly meniscal related things going on. They'd maybe lose a little bit of terminal knee extensions, whatever. They may require some APs just to kind of restore that terminal knee extension range. They might need a little bit of facilitatory stuff, like a little bit of K-tape, just to kind of give them a bit more proprioceptive feedback rather than anything corrective. But those little 1% extra gains almost kind of add up and maybe tip them over the threshold. And I think at that elite level, performance, when it's down to such narrow margins, sometimes those little 1%ers actually can be the difference between playing, getting injured, being a little bit quicker, thinking about the little things like ground contact time and things like that as well. Like we try to work quite a lot on that to try and almost, again, you don't know how many injuries you're going to prevent by making that a little bit better, but if they are a little bit more robust, they can move a little bit quicker, they can adapt to an external tackle coming in, for example. You don't know how much that has an impact, and it's so difficult to measure. Everything in terms of top systematic reviews, nice guidances, it's all reliant on repeatable evidence that you have. But I think the reality is probably within sport, you are going to get individual situations, and that's why I think it's a very clinical reasoning-led approach, and you have to have your own almost asterisk findings we call, sort of worked with almost, these are the important things to get this player performing well, and that's what we're going to monitor. If we can keep those levels up and they don't drop off, be it anything from like a joint arthrogenic structure like a knee, or if it's like a tendinopathy that you need to do the top-ups with the loading bits. Again, it's individual and bespoke like it should be with everybody. But again, I think the access and the time that you have is probably a pretty key factor in that. Really.
Yeah, but that's the thing. You've got more time to tinker, but also it's measuring up that expectation as well. You know, from the players, from the coaches, from being seen to do more and to be doing all you can and throwing the kitchen sink as you've described it. Those interventions, say on trying to help with that terminal knee extension, is that often the difference between them training or not, or training and training well and being able to participate fully, means that then there's almost if you, regardless of what mechanism we're implying, it's you're making a case for the fact that because you're doing that as a means of them then performing, and that can not just mean training, of course, you know, it can be before games and the like. That logic just doesn't map as cleanly onto private practice. Occasionally it does, you know. You'll see people on a Friday before a race on the Saturday and stuff, and those slots getting crammed by, especially as events start happening again. Yeah. But you don't get someone coming in saying, "I need this doing for this big park run tomorrow that I'm going to do every week for the next." It's kind of is less applicable. Where does it get? Do you feel there's an area where it gets carried away and where it really becomes kitchen sink stuff that almost is for the sake of being seen to do stuff and for whatever mechanism or reason? And you can, I invite you to say as to what you feel the key pressures are, be that athlete, coach, agent, anyone like that, directors. But I think that when I do hear about it, both interprofessionally through colleagues, sometimes frustrated, from even ex-athletes, frustrated when they look back over it, especially those that then interestingly retrade into our industry. But then also seeing in the media and stuff where it's just like, this particular high-profile athlete needs this particular version of seahorse placenta injecting into their lateral jaw to help their knee, right? It's so whimsical. I know I'm beyond cartoonish with that example, but where is the line where it gets carried away, and what is the mechanism? If you do think that there are areas where it's over the top, what are the mechanisms you think that are fueling that? What pressures?
Yeah, I think the culture that you are in will drive that enormously. So I think the culture changed quite a lot in the sort of 6 years I was there. It was I sort of touched on it before, it was a very passive, very much if some player wasn't right, they would come to the physio department expecting to be fixed.
Right.
And that was hugely demanding. So there was two of us. There was the head physio and myself, basically managing 52 players. And understandably, you're just fighting fire that whole time, and you don't have the time. I know there's this sort of almost looking at it from the external side that you've got hours and hours with everyone who can do whatever. At that time, we were pedaling so hard just to kind of literally put a team out. I remember we had one game, it was a friendly we had, granted, but we had one back available who was a senior player, and they were getting massaged and treated every single day. It was very much the opposite to what should be happening.
Right, yeah. But hard to get out of that, though, once you're in it. It's like, even though you know it needs to change, you've still got to get...
Yeah, that dread... You were just looking at the door, this revolving door with just like this devastation, and your eyes would be rolling. You'd just be like, I can't even get in the gym to observe people doing rehab because there just isn't the time, because I'm just trying to patch people up. And that was awful. So then we had a real hard look at what we were doing, and we ended up sort of standing in front of the team and doing like a big presentation really on almost shifting the emphasis from this passive kind of approach really to them taking that kind of locus of control really in terms of them being and owning their own bodies. And we tried to kind of almost, it went a bit American, it went a bit professionalism, and there was some other bits like refueling and all these kind of things that you were kind of going into. But it was really important to make that shift. And we really kind of introduced that this is on you guys to make sure that you guys do this in a morning, to do these 4 simple checks. There was an app that you would go through as a wellness app that, to be honest, some of those things, again, are really useful subjective markers that you're going to use. If everyone's feeling ridiculously run down, exhausted, sore, and they are 24 hours, 48 hours away from a game, they're probably going to go into that game 80% going into it, whereas you want them nice and fresh. And obviously game day is where the kind of hard yards should take place. But if they are absolutely goosed going into it, injury rates will go up, their performance will go down. Coaches panic, obviously, because they are then losing. They want to train more and practice more because they don't feel like they're rehearsed. So you end up in this awful, dangerous situation, really, where you're just overcooking and kind of overloading all these individuals. But there isn't the time and no one's happy. So yeah, the big shift for me was very much giving them the emphasis to go.
What do you feel fueled that shift? You've mentioned already a couple of things, so I imagine it's not just one thing, but was it just a knowledge that this was unsustainable and also, you know, not actually yielding the results for performance that you wanted from your department? Or how much of it was just a reflection on things like that macro evidence and a better understanding of mechanism of effect around those times, as well as better data coming through from other clubs, etc.? What fueled that need? Because it sounds like quite an overt moment, really.
Yeah, I think, and I guess you got to probably think this is maybe like 8 years ago almost. We had only which seems a bit crazy in pro sport worlds, but at that time GPS was sort of just coming to fruition in our world. And I think people were playing around a little bit with data as well, and you were kind of going, well, what are other clubs doing? And you could kind of communicate amongst your medical departments and performance departments really, and talk through, what are you doing? Like, are you doing double day sessions every single day, plus weights, plus injury prevention? How are you formulating your week? Because that is also like a huge thing that we looked into, to make sure that come game day we had player availability and actually they were in a good place going into it. And I think that changed a lot, and that was an eye opener for us. I think we're quite a nice profession in terms of people are generally quite helpful. Some people aren't in that world. They're very closed doors, protective over what they're doing with their athletes, but most people are great people in that world and are similar minded. They have the athlete well-being at the forefront, and they will share some data with you, depending on how well you know them. They will share more or less accordingly, of course. But I think that shift, we had quite a lot of old pros who'd probably been there. It had not been the culture to do or be proactive with their own corrective protocols, checking themselves. They were just people who kind of came in, did what they needed to, and then toddled back off again, and they'd wake up pretty sore on a Sunday. I mean, it's not that long ago since rugby wasn't even professional, so it's almost moved on a heck of a lot from those worlds, really. But yeah, I think it's been an education thing. I think certainly in terms of getting consistent results, and again, if you kind of look at the Leicester glory year when they kept everybody fit, that player availability and having your consistent players playing, that was key. And almost that as an education through the coaching, the players, and the kind of wider staff really was a massive element.
That seemed to be something that came through in rugby union almost ahead of other things, where there was, and I think the media picked up on the fact that then that player availability it correlated so strongly with the performance, you know, the actual results, should I say, and that, whilst it's kind of a known, and increasingly so across all sorts of different sports, it felt like the way in which the rugby unions sort of changed, the body types changed and stuff. I remember I went to a Len Funk lecture once, and he was describing the literal size of I can't remember the time frames, I always messed this up, but I think it was like your 1980s forwards are now smaller than your 2010 backs. And then so it's just that those sorts of changes and the demands on people, as well as then the professionalisation of the sport, both literally and financially, but then also what it needs to be medically to ask those sorts of things of those sorts of humans. So it's fascinating. You've mentioned culture a couple of times, which I think culture being almost like it's fed by all sorts of different stakeholders, from the fans' expectation right the way through to directors' expectation, the players of which you have, the age and the background and the cultures, the actual national cultures even of imported players. What would you say, if I had to sort of have you give me a clue as to what of those stakeholder groups most fueled the culture that pressurized the medical system, right? The expectation on you as a medical team that might have influenced those behaviours you've just described?
Yeah, I think it's for us, and it may vary club to club, but I think certainly the coaches and directors, and in rugby, the director is almost like the lead coach, really, and are dictating down that avenue to the forwards coach, backs coach, line out coach, etc., and they're guiding what is happening. So the director hugely influential in terms of managing injuries. Again, they've been around the block long enough to know how long a grade 2 hamstring should take to come back again. You're always going to be quite wise with it. And if you think it's a 4-weeker, go for the old 4 to 6 week classic. So if you turn them at 4 weeks, you're the best physio ever. If they grumble a bit or you have little curveballs that come along the way, you've got an extra couple of weeks to play. Sure. Yeah, you do. I think the challenging thing probably in that world is the coaches are very, you know what, this is an injury we've got, and this is probably where the imaging thing comes in as well, actually, because although you've got your clinical reasoning, you could probably make a diagnosis and make an informed decision over what grading it is, what muscle tissue it is, the location, etc. The coaching staff will more, or the director in particular, for us, would want a scan to confirm exactly how long that timescale was going to be. A very kind of old school biomedical approach, really, where they don't care about biopsychosocial models or that kind of stuff and all the barriers that come with all the flags with it. They care about, this is a structure that's injured. We know it's going to take this long for it to recover. If you don't get them back in that time, that's your mock-up. But you are clearly, that's the big difference.
Do you think would it be too much of an ambitious thing to try and educate because we know that the population at large, especially those that have got a sporting bent, have that biomechanical and biomedical and structuralist approach to things, and we understand that that's pervasive across culture. It would be too tough a task to then say, well, things are a little bit more complex than exactly just how torn this hamstring is. That maybe seems too ambitious at that level, and almost the power dynamics just do not suit. What you've done there, where you've presented to the team, and no doubt still had to go about that delicately, the interprofessional respect is there. No doubt there's respect, of course, to the medical team from the directors, but there is still a power play when they're signing off your pay slips and stuff. There is something to be said for that, and that pressure does loom large from what I can gather. Do you wonder, though, let's get stuck into the imaging thing, because I've been on a massive journey with this, and in preparing for this discussion, I really found myself far less decisive on it than I used to be, where I went through and still have moments where it really pisses me off when, especially in the media, you've got someone that it's as if that is the be all and end all, and therefore the way that translates down into patients in standard private practice and NHS departments, in the implication that the structure is all that matters, that when someone of a high level then is there, hobbled off the pitch, happens to be interviewed, or the manager is interviewed about them typically, and we'll see what the scan says tomorrow, as if there's nothing that could be, and I wonder, and we'll come back to this, as to what the therapist's role could be in with regards to that media savviness and stuff, and that the general natural distance we've all kept as medical teams from those things. I think that's one of the areas where it's not playing well for us. So I'll probably remind me to come back to that. But my question for now is, when I've gone on that journey from being really frustrated for a time, but then also starting to respect the fact that those time frame estimates on prognosis, they just matter more in that world than they do in this one, right? And this one being, I'll say, in a studio that is in our private practice, is that you're giving those prognoses and guesstimates, but fundamentally you are less accountable to that. I mean, the patient naturally and rightly should, and certainly parents of adolescent aspiring athletes will hold you to those things, and you do want to make sure you give you a good and sensible guess. But you rarely need to be informed as sensitively by the imaging. But in sport, those timeframes have huge cost implications as well as then reputational implications on the club and of the medical department. So, as I say, I've softened, while still frustrated by it generally, my understanding of it and speaking to you and others has lessened. But what does that environment of the scanning access and readiness, can you just muse on the ups and downs of that, the positives and negatives of that culture?
Yeah, of course. So I think for me, imaging certainly has a role. It has a role and it will exist indefinitely. I think the difference between rugby and football in terms of the amount of imaging that happens, from my experience, is enormous. And I think that's probably financial driven in some respects. So, for example, talking to friends who work in professional sporting worlds in the Premiership, they're medical. They basically scan every single joint to make sure that they are aware if there are any underlying issues that may be occurring. I think in a rugby world, when we would do a medical, for example, we would obviously assess them as you probably would do in a normal MSK thing. You'd go through all the range of motions, you'd do the overpressures, you check the power in certain ranges, you do all your hard neuro bits and pieces, all that. If there was anything that you weren't sure on, that you were thinking, I wonder if there is something grumbling here, why can't they have why haven't they got an output that they're, I don't know, that's not in keeping with a pain limited thing, they just are weaker, that kind of thing, or if there's a joint that's looking a little bit fused, that kind of thing. Or if they've missed training in times gone by, they've missed game time because of it, or they've adapted the way that they train, or they always tape something, we may decide to image that. Now, that covers us. Now, I think there's more litigation within football worlds. I know Sunderland, I think, was one of the first clubs, which I wasn't that sad about as a Newcastle United fan. But again, like in their worlds, it was the first time that someone had actually sued the medical department based on kind of inaccurate diagnosis and signing a player without clearing all of these underlying issues. So they'd sign someone, we're paying them X amount of £1,000 a week. But actually they had this underlying issue that was stopping them playing, and they were still shelling out thousands of pounds for this player. So understandably, who is responsible for that? And I think in the heart of hearts, as caring, sharing professionals, we hope that, everyone will be dead nice. But actually, when there are millions of pounds at stake, if someone is signed with an issue that they cannot represent the club with, then it really causes frictions, and probably so it should. You're relying on, the whole reason of a medical is to try and flag and screen any issues. We certainly had on the back of imaging, which has gone a little bit side, this caveats for whether or not we would continue someone's contract, for example, based on they may have an underlying problem. You know what, if this means that they will miss a percentage of the season, or they're not available for a certain percentage, it was a bit cutthroat. And whether, again, that's financial or how that's driven from upstairs, again, it's an interesting one.
How did you, because that's a really interesting area I hadn't planned to wade, but we're there now. How comfortable were you on the fact that there was almost like a fatalist attitude to certain structural issues, whereby we all know, especially in the environment that you're in now, you'll encounter them as much as I do, whereby people blow you away with what they're able to do with what are structural issues, because they're either got developed compensations. We know that the complex biopsychosocial holistic phenomena that is pain and injury and the various different determinations that you see, as well as the social circumstance that people are able to what they need to ask of their bodies to earn a living, etc. You've got such wide variety there that sometimes things are compatible. When you think back to the fact that sometimes decisions were made based on a best guess of someone's, say, structural anatomy or what they were tested in that moment, how comfortable are you with that environment, and how much could you see it being able to be adjusted if you are uncomfortable?
Yeah, I think you're right. And I think it is astounding when you look at and this is the whole marrying up, isn't it, of what's on an image and what someone can functionally carry out. And yes, they might need a little bit more love to try and get them through various things, but they can still perform at that level. And rugby players, they do not have pristine joint surfaces. They always need to have some ropey bits with them. Sure. And again, it's kind of just taking that with a bit of a pinch of salt. And again, reasoning wise, how is that going to impact them? And is that, and I think that is it's a challenge, really. You're going to use all of your evidence and objective markers, subjective markers, all these kinds of things alongside the imaging to make a decision and a recommendation. Now, whether or not this is a fairly new thing that people maybe are going to get sued or what have you on the back of signing people, maybe I'm a bit lucky that I've kind of almost jumped ship before that kind of world comes to fruition a little bit more, but it's a real challenge in it. And I think that's probably why imaging as a secondary backup option maybe is done more for the lip service or whatever for the coaches and just to cover our own backs than it is to actually guide clinical decision and how we manage that individual. So I think maybe traditionally, or looking in it before I went into sport, thinking, God, everyone's getting an image and basically any monkey can do that. Then you just basically get a time scale, or someone goes for surgery and the surgeon sends you a protocol through and you kind of go, well, it's going to take this amount of time to get back. And we had a classic one actually with a guy who dislocated his toe, got it put back in again, plantar plate ruptures, all this kind of stuff. And he had this person in cast for say 6 weeks and then just said, oh, you'll be on the Alter G at 8 weeks. And you go, well, that isn't going to happen. Like, it's going to be stiff. It's going to be weak. He's had no exposure, all these kinds of things. So it's very much on that sort of situation going, rather than being protocol-led time-wise, for me, was very much a criteria-based thing. When they're ready. When they're strong enough. They're ready once they can do X, Y, Z. We can kick on to the next
This is the
level.
range that we need for these particular activities, and therefore it's only when it can do that. Otherwise, you're going to draw on those compensations, especially when they need to be at high performance. I think that's another area I wanted to go, where I think in an MSK setting, when we're just thinking about recovery for pain and injury, and we don't necessarily, the performance is sometimes latterly, or it feels like that's what you might pursue with regards to end stage. I think many of us will be integrating that mindset throughout these days. I think that's especially on a sporting level, we kind of do that regardless of the sort of competitive standing that they have. But where I have more sympathies to the fact that you will need someone to move, not necessarily well by the textbook, but well by their standards, right? Move at their best, is because the performance is the role. Whereas when we're kind of working pain, injury and stuff, we can be a bit more relativistic and be like, well, if that's a bit stiff and therefore you're compensating like this, then the ability to just be able to do the thing is all that matters to you, is the entry level. And so you can be far more liberal with that attitude. Whereas in that elite world, at that high end of performance, is that said stiff toe, if that has a significant biomechanical adaptation just to make them be able to participate, and that then means that they are less decent at whatever actual complex activity that they're paid to do at that sporting level, that's going to matter more. It just does. It matters more for a rugby player than it does a plumber if they're having to compensate. And so I think, again, it's where almost these things get conflated too clumsily. And I wanted to invite you to say, what, now that you're in this sort of more MSK environment than sport, how much do you consider them to be synonymous? Do you consider yourself an MSK and sports physiotherapist, or do you think that actually there's enough distinction there based on what I've just said with regards to aspiring people to performance, that they probably need to be respected as their own disciplines? And so it's kind of, I'm always on a bit of a yo-yo with that.
Yeah, and I think they are. There's overlap, isn't there? I don't think you can ever say that you are purely a sports physio or you are not. Because I think we just get served up all kinds of weird and wonderful things. Like I've had, people sort of managed in very bizarre ways, crazy humeral fractures this week that have come in some respects, and they've just been put in cast for 3 weeks because of COVID and not had operations. And you kind of see what a mess that is now that it's been operated on, and he's got all these weird hand symptoms and all this kind of stuff, all the way through to I've got kind of GB lacrosse players and things as well. And you kind of go, well, across a huge range of different areas, the principles that underlie it are pretty transferable. And again, I think it's that clinical toolbox thing that you're going to probably have loads of different tools in your toolkit, or kind of feathers in your bow, whatever it is. But again, you're going to probably draw upon them in different weightings according to who it is who's in front of you. If, like you say, you've got as just the example you use, like a plumber who maybe stands all day, you don't need to worry too much about his big toe extension at all. But then if someone is running and they don't have that they can't achieve that normal kind of windlass because they've got no movement in it, and they get raging Achilles tendon issues maybe as a secondary problem to it, and that's limiting them, then we have to address that. Otherwise, they're probably going to keep on breaking down with it in future. And I think it just depends on who comes in, really. But again, it's just going to vary.
What do you feel are the skills that you have from your sporting background that you bring to your MSK role now that you wish everyone would have?
I think people used to talk about rehab being something that wasn't done very well. And I think when I look at people who've been transferred maybe from other worlds, I think that is the area where we haven't progressively loaded people appropriately or found ways for them to move early enough to get them moving. So I think, I don't know, again, kind of thinking about private practice, I've got a guy with horrendous back pain, had it for absolutely years and years, weak as a kitten. And we just did all of his rehab in a forward flexed position, supported, got all his glutes firing, all of his kind of hip flexors, all that kind of stuff working, fully supported. And he actually got strong in that position over about a kind of 6-week process. And with that baseline, he was then able to kind of do a little bit more. So it was transferable. But I think the awkward carousel of sadness, if you like, that he was in was just everything was sore. Whenever he tried to train, he was sore. He just didn't have any guidance. But I think the beauty of physiotherapy in particular is finding ways that we can get people to train and strengthen themselves, even when maybe more common activity-based things aren't possible. So bridging that gap. And then also I feel like people jump too quickly, or it's just not a progressive element. So like, I guess what we had as part of the injury prevention program at the club was take something really simple, like an exercise, like an arabesque, a single leg RDL sort of thing, and just offer progressions, levels that you would build on top of that.
Right.
So then they could build that up again. So it's almost, you'd maybe have them on an unstable surface, stick them on an Airex or a Bosu or something, add some rotation in there, closing eyes, add a weight into it, maybe make it a little bit more dynamic. So it's progressive rather than just this haphazard 3 or 4 totally random exercises that you go, and then people can see the journey of where you're trying to get to at the end. And it's often we have in our heads, I think, this image that we're giving you all these exercises for good clinical reasoned things in our head, but actually how do they all marry together, and is that going to end up?
That's a great point there, spelling out that what these exercises represent in their functional endpoint, and that journey needs to be articulated and seen by the patient, by the athlete. That creativity you're describing almost as being the sort of centre of that is that you've been able to be creative with your rehab design and apply that on such a frequency that therefore you're getting almost like a career's worth of rehab in 5-6 seasons almost for what many would have because of the intensity of that role. I think that we hadn't planned that, but I couldn't have thought of a better answer, and I agree wholeheartedly. And I worry about the fact that, and it's been documented on Physio Matters, Chewing It Over and Beyond, really, and mentioned a lot at Therapy Live, is that the time frame afforded to various different contexts for rehab, and the fact that you might have some services that are limiting at 4 sessions when the best evidence suggests that, tendon loading in 4 sessions, you've got to cross your fingers and give people protocols. We're going to moving back away from a clinical reasoned approach to having to suck it and see, and not even supported self-management, but just suck it and see and crossing those fingers. And so the fact that you're saying that the experience that you've been able to have to be creative with rehab is an opportunity that in sport might be one of the few areas where you can really be afforded that experimentation and that creativity, which is a shame. I mean, it can't be protected like that. It needs to be, especially junior therapists. Like, God, you've got to go and play around with it a bit, haven't you? And the fact that you hear stories of them not being able to do that because of service design being so restrictive is a massive concern. I can't help but ask the flip side of it, though. What do you think there are? What things did you have to experience and learn in sport that you feel not only aren't helpful, but also could potentially hinder if you were to do a lot of that now in your current role?
Yeah, I think it's probably those, and thinking back, predominantly probably South Americans and the French were very, very reliant on us and they would be in every single day, and it would just be a culture of them coming in, getting rubbed, getting mowed.
Right.
And it was that sort of thing that we probably just need to nip in the bud, really, and trying to make individuals not reliant on us doing it. So very much putting it back in their court. They'd be it self-trigger point release work, heat stuff, self-massage bits, self-stretching bits that they may be working on, little activation things. Heavy.
Were you able to convince them that it wasn't doing what they thought it was doing? Because a lot of that was that I know exactly what you're meaning, and that the relevant national cultures that can feed that perception sometimes, and just the expectation, because that's what's always been done, is they often perceived that those things were corrective in a really obvious and overt mechanical sense, that they were having their anatomy changed on a daily basis, etc. Were you able to get those pennies to drop, or was it instead like just switching in other strategies so that then, because changing that mindset would have been too difficult? How did you have to go about that?
Yeah, really, really challenging, to be honest. And sometimes, you just have to go through the motions, really, of just going through it and trying to educate. And I think that probably if you are doing manual therapy and that kind of thing that you don't feel like is very useful, I would just say in that time, the opportunity to educate is actually almost quite a nice one, because you are doing something. You're not just sitting opposite someone. They feel like they're getting something, but then you're feeding into that that system, really, that actually, you know what, I've rubbed down lateral quads for half hours just with misery, probably oozing from my orifices and whatever, but it was just like, this is soul-destroyingly whatever. And there's no measurable change at the end of it. But in terms of them and preparing them psychologically for games and being prepared in their own superstitious way that this is what they needed in order to perform, you'd almost justify it that way. And to be honest, if you just, and we've had scenarios like this where some physios just hate doing any hands-on work in that world, and it's challenging. And I think they end up coming up with some really good agreements between them. So they kind of say, look, if I do 5 minutes of manual therapy with you, you owe me at least 10 minutes worth of self-directed stuff. Or you make a contract. So you say, look, I will give you this amount of manual therapy, but you owe me this much, and as part of your management of your processing, you need to do that. And I think they're quite nice ways, in some ways, to do it, that you're almost buying, with little coupons, chips. It's
a negotiation, isn't it? Definitely. What I think is a fascinating tug of war that happens is, you mentioned the sort of psychological, social benefit, as well as the habit. You mentioned even superstition. I think that if then there were a set of players that were insistent that the medical team sat down with them and went through their horoscope on a weekly basis, right? And it was I'm going raw superstition now, where it's like you can't think of a mechanism, a feasible mechanism that any medical establishment would ever be on board with, and say, no, that's we're with the highest order. It'd be a hard no, and it'd be articulated as such. It's almost this middle ground between, you've got legitimate medical practices, of which manual therapy is of course included, therapeutic touch being an important component of what we're skilled to deliver. Then you've got horoscopes at the other side of it. Because you can get a meeting of those worlds, because of what is motivating them seeking that care, it becomes such a messy thing. And negotiation is the only way to think about it, is because being absolute in that direction means you're losing some of the talent pool, because often brilliant players, imagine not being able to tap into that base for your club. They'd soon find another therapist, because they want to be able to have those and sign those players. But then similarly, you corrupt the ethics of the medical department if you overindulge their perception on superstition. So how much do you have to, as an individual therapist, grapple with that, and how much do you get kinship amongst the team, where you kind of all help each other, counsel each other on how to do that?
It's a tough old gig, that, isn't it, to be fair? I think for me, you are going to have individuals who that is part of their routine. That's what they expect. That's what they want. If they're not happy, they'll go upstairs and they will complain to the hilt that they are not getting what they need to perform. If they're not performing and then the coaches come down hard at them, they will then turn around and say, well, I'm not getting what I need from downstairs. And that has happened with a couple of Argentinians back in the day. And you kind of go, well, there is no evidence to suggest that this technique is doing anything for you. It is probably not going to help. We were lucky we had a massage therapist who was delighted to kind of just deliver hands-on therapy, and just you'd point to an area and he would just roll it, and he kind of got nicknamed the human foam roller for a little while, sort of thing. And it was a bit harsh, because he was actually a great sort of therapist. But I mean, if you do toy with it, that I feel like I really want to make objective, measurable changes with people, but sometimes that isn't possible. And I think I probably dilute or kind of almost supplement that with almost using that time to almost try and educate and get a bit more almost sort of educational side of things into it, really. You know what, the reason that you're probably getting tight and stiff is because you're not strong enough, or you are maybe needing to do some little extras. Like, can we go and have a little look at these afterwards and just see? And then hopefully on a sliding scale, it almost meets somewhere in the middle where they maybe come for little top-ups now and again, rather than this soul-destroying, just rubbing aimlessly through a soft tissue. But it really is a challenge. And I think, there are, I'm sure, no doubt, people who go into physiotherapy practices and all they want is a sports massage, and they aren't really bothered about objective changes, but it makes them feel better, and they feel like it's rubbing knots out and all this kind of stuff, which you're not going to change. So.
Yeah. And obviously the opportunity, and one of the things that motivated us to go big with it and build a practice around a brand that was kind of confident that you're not going to. People come there, they've come with a misconception. It's unlikely that they've come via testimonials and word of mouth on the specifics of what is going to happen. And people come in, I hear you guys do things differently. Now, it makes us cringe because we wish it wasn't different. But yeah, rehab-centric practice that isn't then centred around passive modalities, or an expectation that the customer is always right based on their own sense of perception, which is obviously non-expert. It's patient-centred, but based on their functional goals. That shouldn't be novel, but it is. That being able to sort of design brand and expectation can help with that. In the professional sporting world, that sometimes can carry over from sort of legacy of those departments, of those clubs' perception. You've got especially more so in football, but you've got clubs that have got Arsenal signs Frenchmen, Wolves sign Portuguese players for potentially up to 10-year spans and things. You're going to get those natural overlays that come from those national cultures as well. And so it becomes very complex. And I think it needs to be respected almost from all areas of our industry. The fact that these are pressured environments with very unique circumstances that influence them. Much like in private practice, you've got that one-to-one, someone's literally about to tap on a card machine as they leave. There's an interesting dynamic there with regards to the where the power plays there. In professional sport, it has its interesting equivalents, but deeply political and often highly pressured under a media spotlight as well. And so I think above, I'm sure we've covered many things, but in chatting about it like we have, I hope it gives that, giving each other the benefit of the doubt, respecting each other's difference in context, not knowing enough about the individual athletes to then make assumptions on each other as therapists, and then just give each other the leeway and ask the questions, I think is the key one. I do want to then say on the branding side, I want to understand as to what then inspired you to try and take some of your journey, your knowledge, your passion for the good stuff rather than the nonsense, and therefore create something in Grow Physio that made you then sort of spread the word and film it for the masses.
Yeah, so I think for me, I firmly believed that I was very privileged to kind of get into that world as well. And I always found it really frustrating that we couldn't bring people in and help students, help people who wanted to. We had endless amounts of requests that came in, but it was just almost a carte blanche. You can't come into the first team environment. We can maybe offer you an evening in an academy at absolute best, but only if you've got contacts to the hilt in it. And I don't think it should be that way. I think people should get an idea of the flavour of what it's actually like to experience what that world's like. So for me, with the Grow Physio platform, that's a sort of separate entity in itself that I kind of almost go through the realities and the actual behind the scenes. What is it actually like? What does it involve? What does a normal working week look like? How might you get there? All the different journeys that I went down and all the other sort of physios who were in that world, if that's the way that you want to go, that maybe you could kind of almost meander your way through to get there if you want to. But is that actually what you want? Because it's a lot of volunteering, a lot of free hours that you're often going to have to put in, maybe go into an academy. And again, because although I feel privileged, the flip side to that is people see it as a privilege when they often make the salaries that are associated with this. So then they almost get people on an absolute peanut, undervalue the profession for the amazing role that it can have. But at the same time, people need to know, because if they get there and it's not what they want and they've put on all of these hours, it's probably going to be something that they're pretty disappointed with or burnt out or whatever. Right. So alongside all of the injury educational side of things that I've put together, that again, part of the latter stages in the last few years that I was there, I started to create little motivational videos for people who maybe had injuries and whatever, to see their progress, which I think even if you're working in private practice, again, if you've got the buy-in of the person you're working with, you might want to do something like that if it's an ACL over a 9-month period, for example, that you're trying to return them. It's really motivational to do. But I had all this footage of injuries coming through that we had, and then with the obviously the adherence or the kind of consent from the players, really, a lot of them have been really happy to share that and use that in an educational format. So again, it shows it's very rarely linear in terms of the progressions that these athletes have. It's not always you know what, you'll follow this protocol and you're guaranteed to get better. There are going to be twists and turns. Different tissues will respond differently. Individuals will move differently. There'll be different challenges. Again, ACLs, all sorts of different things that can come out of that. But I think probably within a professional sporting world, if you've got kit to evaluate where they are at different stages, like force plates and things, you can get a lot of those things just by using things like, I know you guys have got like a microfit handheld dynamometer, that kind of thing that you're going to use and widely usable. So they're really useful to get objective, measurable markers to highlight asymmetries and things between different sides. Where do you want to try and get to in order? And that's when you can kind of use the literature, hopefully, and say, look, if you've achieved this number of reps, this amount of strength output, whatever, you are probably less likely to get injured.
It's those confidence intervals, isn't it, as well, and informing your diagnosis as well as your prognosis, and those time frames and stuff is sometimes where you do feel lost as a junior therapist. So what can inform those variables is good testing, as well as then the knowledge to apply that sensibly. I think your work, especially looking into it, has made me realise how Physio Matters and various others have ended up long form, very cerebral, talking about the evidence, don't regret it. But I think we have neglected some of the practical aspects. And I think that your work has made me realise that you can muse over the shortcomings of an RCT. We can commentate over the interesting dynamics between Seth O'Neill's critique of Ebony Rio's work and then Jill Cook's defence of it. It matters. I'm not diminishing what we've been able to do there, but we need to be able to strap an ankle and to be able to understand how you might be able to offer some temporary resistance to inversion injury in someone that wants that in order to be able to perform. And that we're probably in a world, as the pandemic descended, that then disrupted clinical education for students, but also for the environment we've just described, where new graduates are going into to services that aren't conducive to creativity. Then I think your platform being able to bring with it those insights you've described, as well as those practical applied bits without the nonsense, without the, and this is what this is doing to the lateral line that will stop you getting jaw pain, which unfortunately sometimes these things are coupled with. You know, it comes with the kind of people get carried away. They think, oh, well, I'll do a 20-minute video on this particular taping technique and add all this fluff as a means of then just justifying the fact that, you know, Steve Miller at Grow Physio, here's 3 minutes on this and here's 10 minutes on that, because that's the time you need to give the message across. And the message being, seems that you conclude most of it has been, give it a go, let me know what you think. You know, it needs to be that suck it and see, try and test it, less pressured environment. And that atmosphere really comes through on your platform. So well done with it. Where do people find it, and where do people find out more about you in the future on socials and the like?
Brilliant. Yeah. So growphysio.com is the website. It came from nowhere. And as I say, as I probably should mention, really, that the whole drive of it really was to almost support the student cohort coming through, really. So I was very aware that people couldn't do practical placements in hospitals and whatever because of COVID. I've done some virtual ones, which again is a really useful sort of process. Got tons more out of it, both parties, I think, than we ever thought we would do. Right. But yeah, growphysio.com. It has 7 different courses that are on there currently. You can have a little look at grow.physio on Instagram. It is packed full of kind of educational things. We're on Facebook. We've actually got a members group now that meets once a month and does like a mentoring thing as part of that. And then there's also the Grow Physio Huddle, which is our little Facebook group, really, that just, again, invites people to encourage discussions, questions, some people wanting and starting doing their dissertations, that kind of thing, what topics might be of use, and just getting some different ideas from all these different professionals, because they're not, the wide range of people has staggered me, really. It was initially set up as something that students, new grads, anyone who wants to go into sport worlds are, but there's people with 10 plus years experience of working in professional sport who are using the platform as well, and they're a great resource draw upon. It's just kind of trying to bring them all together, really.
That community of practice idea is something that everyone has noticed has emerged around yours and other platforms in the pandemic. I think that it kind of has been a big leveler, humbled us all, and I really love the fact that everyone's sort of, as you said, the atmosphere is one of cooperation rather than competition, which has been lovely. Really enjoyed chatting with you, Steve, and thank you so much. For those that haven't noticed, Steve's been helping us with some stuff. He was moderating at Therapy Live, involving here now on Physio Matters podcast, but also, especially with him being our local lad. I love that he said at the start, he said, come down south to Manchester, which always cracks me up as we consider ourselves northerners. But to you lot, we're southerners, aren't we? But we're so lucky to have you locally and in the profession. Thanks for all you're doing. And thanks for joining me today.
You're very welcome. Thanks so much for having me, Jack.
Cheers, mate.
Really appreciate it.
Nice one.
Thanks there to both Jack Chew and Steve Miller, who I agree with. Manchester is pretty south from where we are in the northeast here. I thought that was great, a really thorough and self-scrutinizing look at MSK within the sports settings. So I hope you enjoyed it. As Steve says, you can get to him at growphysio.com. His number of courses, brilliant project that he's launched there. He's also one of our mentors. So Physio Matters has launched a clinical mentoring program in the recent weeks. And you can find us at physio-matters.com/clinical-mentoring. You can Google that and you can get to us from there. Searchable also on our social media pages if you click on the link tree on our Instagram page. So all that's left to do is to say thank you very much to our sponsor, Rehab My Patient, and also to, I believe, do the cheesy sign out myself, because it doesn't look like Jack's remembered to ask Steve to do it. So here we go. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. See you next month.